This is a device that facilitates jaw recordings for the complete edentulous patient, or a combination edentulous arch opposing a dentate arch, or both arches being dentate or partially dentate. This device also stabilizes denture bases when utilized to fabricate occlusal splints and when equilibrating new, complete, or partial denture prostheses. 1A. This is a completely edentulous patient's model cast. You will see the striking plate is mounted to the maxilla and a pen receiver with the pen on the edentulous mandible. 1B. Displays an edentulous maxillary arch opposing a partially dentate arch. 1C. Demonstrates complete dentate on both the maxillary and mandibular arches. 2A. Demonstrates a complete denture in which the jaw recorders were mounted to facilitate the fabrication of an occlusal splint. 2B. Demonstrates a complete denture with the jaw recorders mounted to facilitate the equilibration process. Note the blue and red articulating paper. What are jaw recorders? Jaw recorders are synonymous with the Gothic arch tracing concept, utilized beginning in the late 1800s to take the vertical and centric relation records in place of wax occlusal rims. The principal therapeutic value of these devices was intended to eliminate physical interferences at the occlusal level. For example, tooth or occlusal rim interferences. The jaw recorder device allows physiologically unencumbered mandibular movement. This device permits the patient to move the mandible without resistance, allowing the jaw to move in a forward, back, and side-to-side position, thereby allowing the practitioner to visualize protrusive, eccentric, and centric relation movements as tracing marks on the striking plate. Note the arrow. At the top is protrusive. The apex of the arrow denotes centric relation, and then to the left and right of the apex, the eccentric positions are displayed. When the patient slides forward, this is noted as protrusive, and when the patient slides back, this denotes centric relation, and then sliding side to side denotes left and right eccentric. The patient is not manipulated. The patient is asked to freely move their jaw forward and then back. It is suggested that we inform the patient to slide or rub as opposed to move for a better understanding. The patient should close to allow the pen to touch the striking plate while sliding in all required positions. They are asked to repeat this several times to be assured that there is a smooth, repeatable tracing. This slide shows the newly designed Massad Jaw Relation Recording device. It will be delivered on the sprue with 5 pieces. You will note at the top there is a parallel spacer plate. This plate is utilized specifically to assist the practitioner or the prosthetic technician in mounting both the maxillary striking plate and the mandibular pen receiver to be parallel with each other and provide enough pen room to take the recording. You will note both a small and a large pen receiver. These are generally mounted to the mandibular arch, and the nut and pin will be snapped into the center socket. You will also note a small and large striking plate. These are the plates that are generally attached to the maxillary base plate and have an extremely smooth surface to allow the pen to slide without resistance. The pivoting nut and pin. The nut is inserted into the pen receiver socket, and the pen is then screwed into the nut. The nut allows rotation. The rotation is necessary in order to have the pen perpendicular to the plate once placed into the mouth. This is unique from other devices fabricated. This slide shows additional various sizes of pen receivers to accommodate most dental configurations. We have found, especially in the dentate patient, that there are various arch widths in many cases, and additional sizes will facilitate ease of mounting. In order to facilitate the practitioner or prosthetic technician in ease of placement of the pen receiver, we have additionally added 4 sizes for various configurations. As you see on the left, the pin and nut have not yet been inserted. On the right, we have inserted the pin and nut for you to visualize the end result. Mounting the jaw recorders for the edentulous patient. On the upper left, we have 2 casts, maxillary edentulous cast and a mandibular edentulous cast. On the right, we have resin base plates, which have been fabricated in order to mount the jaw recording devices. These casts are made from the final definitive impression. This is a close-up of the resin bases. Note, it is important when fabricating these bases that they are fabricated slightly short of the vestibular extension. This is done so that the practitioner can be assured there will be no impingement on any frenum or vestibular attachments while taking the recording. It is necessary for these bases to seat without resistance around any of the peripheral borders. We are now showing the jaw recording device delivered on the sprue. Simply twist off the appropriate sized part necessary to place both the striking plate and the pin receiver onto the base plate. Sizing is simply done, especially due to the fact that the recording device is easily adjusted with a dental lab burr. As seen here on the upper left, we have the smooth side of the striking plate. This smooth plastic material surface allows the dome portion of the brass pin to move without resistance. On the lower right side, you will see the underside of the striking plate with 3 retentive projections to secure the resin used to mount on the base. Note the 2 sizes of pen receivers. In this case, the socket rim is up. This is the area in which the nut will be snapped into to secure tightly into place. However, the 4 pin receivers, which are utilized for the dentate arches, will have the cylinder on the bottom side to allow for additional inter-tooth or inter-ridge distance. We are now sizing the pin receiver to the mandibular base plate. In this case, we are using the long, wider size. Any excess spurs can be easily removed. We are now placing light cured resin around the base, and then we will take the lower pen receiver and place this into uncured soft resin. The pen receiver should be parallel with the cast. This demonstrates the position of the lower pen receiver. Note, it must be set below the height of the retromolar pad. Now, light cure into position. It is suggested that a small amount of resin come up and around the edge of the pen receiver edges to give additional retention. Now place the parallel spacer plate onto the pen receiver. This will snap directly in with firm pressure. Secure the base with your thumb, then put pressure and snap this paralleling plate into the pen receiver. Note, it should fit flush both on the front and back sides. Next, place light cured resin on the pallet of the maxillary base plate, placing the striking plate directly into the resin. Now take both the maxillary and mandibular record bases and hold them together, allowing enough pressure to parallel the striking plate with the pen receiver. Light cure until completely polymerized. Now remove the spacer. Once the spacer has been removed, it is suggested to snap in the nut, followed by turning the pen in with the round part of the pen facing upward to come in contact with the striking plate. It will take significant force to press the brass nut into the pen receiver. It was necessary to make this attachment tight to eliminate the pin from rotating when the patient closes. We are now turning the pen into the pen receiver. The height of the pen will be determined upon the physiological rest position, and then the practitioner will then factor in appropriate freeway space prior to finalizing the vertical dimension. As noted here, we have a complete setup for the edentulous patient. This will then be utilized to place into the patient's mouth, adjust the pen to the appropriate height, and then have the patient slide their jaws forward, back, and side to side to establish the patient's physiological centric relation. Here is another view of the jaw recorder device after mounting is completed. Note that if the pin touches the striking plate at the incorrect angle, the practitioner can then rotate the pen either anterior, posterior, or laterally in order to align the dome of the pen to the plate in a perpendicular position. Note the top of the pen dome should contact the striking plate perpendicularly. Mounting the jaw recorders for the combination edentulous dentate and taking centric relation recordings. In this case, you will see a dentate mandibular arch. We have fabricated a light cured resin base to allow placement of the pen receiver. Place resin to adhere the lower pen receiver and cure into place. Now snap on the spacer. Once the spacer is snapped into position, a bonding agent is cured on the palatal position of the maxillary resin base to adhere the resin. Now apply light cured resin material on the palate, applying enough pressure to position the striking plate to be parallel with the pen receiver. Light polymerize until completely cured. Now remove the spacer. Once the spacer is removed, the nut and pin will then be inserted. This is then placed into the patient's mouth along with the maxillary base. At this point, the pen will be adjusted to the appropriate patient's occlusal vertical dimension. We have now taken the patient's physiological rest position, and in order to obtain freeway space, we are going to rotate the pen downward until we obtain between 1 and 5 millimeters of freeway space. In this instance, we have determined that we will utilize a 3 millimeter freeway space. We can measure this with the use of dividers in order to maintain accuracy. Once this is set into position, you will analyze to assure that the pen touches the striking plate perpendicular. In this case, the pen appears to be appropriately set. Now place an inking solution on the maxillary striking plate. This will allow the practitioner to be able to see markings on the striking plate when the patient slides forward and back and side to side, and then read the tracing marks. The patient is asked to tap to assure that the bases are completely seated, and then to slide forward and back, and then to repeat forward and back, and then side to side. The patient is instructed to repeat several times until the practitioner observes a smooth motion of the mandible, moving in all directions, forward, back, side to side, forward and back, side to side. The practitioner can easily observe the patient for ease of movement. During this process, those patients who have difficulty in moving their jaws should have the ability to become deprogrammed. We suggest that the patient continue this process until a clear arrow is demonstrated. As you see here, the mark of an arrow which will signify both protrusive, centric relation, and eccentric left and right movements. At the apex of the arrow is the centric relation position. Once again, the arrow depicts protrusive, centric relation, and eccentric left and right. At the apex of the arrow, we are now going to adhere a plastic receiving device to keep the patient steady at the apex while taking the record. We will lute this circular receiving ring with a luting wax, which will adhere to the striking plate over the apex of the arrow. The hole in the pen receiver has a bevel which will match exactly with the dome of the pen. The patient is then asked to close into the depression while the practitioner injects a bite registration material. We suggest a polyvinyl siloxane impression material which will set very firmly and will have no bounce after set. We are now reestablishing that we are at the correct occlusal vertical dimension with the desired 3 mm freeway space. Mounting the jaw recorders to balance denture occlusion. Take the patient's completed prosthesis. Apply bonding agent to the lingual of the lower in the area in which you will be mounting the pen receiver. The lower pen receiver was adjusted to fit slightly beneath the occlusal surfaces of the teeth. With the use of a light-cured resin, this is applied and the pen receiver is compressed into the base plate to be secured. Once this is adjusted properly, a small amount of resin is lapped over the top in order to give additional retention. This is then light cured until completely polymerized. Next, the spacer is placed on top of the pen receiver and snapped into position. Light cured bonding agent is applied to the maxillary arch to adhere the resin. Next, light cured resin is applied to mount the striking plate. It is now necessary to take the mandibular and maxillary denture, hold in position, allowing the spacer to align the striking plate and the pen receiver parallel with each other. Once this is completed, the maxillary striking plate is light cured. This demonstrates the completion of the mounting of the striking plate and the pen receiver on a denture for purposes of post-operative equilibration. It is necessary to assure that the mounting of the jaw recorder will allow the denture to close completely. We need to analyze this both from a lingual and a lateral position to be assured that the pen will not keep the dentures from completely seating. Next, we open the pen until there is no tooth contact. The practitioner is then able to slowly close the pen until the first point of contact. Once the first point of contact is noted, articulating paper is utilized to mark, and then this area is adjusted. This process is continued by slightly adjusting the pen downward until the teeth come into contact. The principle here is that the pen and the striking plate will keep the prosthesis from rocking during this process. The denture is gently adjusted until bilateral contacts are observed. Once again, the rationale for mounting the jaw recording device on a complete denture is to prevent the slight tipping of the denture when the teeth come into premature contact. When the pen strikes the maxillary plate, the maxillary denture is seated and the mandibular denture is seated and rotational movement is eliminated. During this process, the practitioner then slowly closes the pen until the first point of contact is noted. Prematurities will then be adjusted, and the pen will then be closed again as the practitioner is checking the occlusion. This shows the finished result with contacts in the fossa of the mandibular teeth contacting the lingual cusp of the maxillary teeth. There are, of course, different occlusal variations depending on reverse bite situations. This is a patient with a severe overclosed occlusion. As noted, the dentures have worn significantly. It is now necessary to mount the jaw recorders onto both maxillary and mandible existing prosthesis to fabricate an occlusal splint to reestablish loss of vertical dimension. The striking plate has now been mounted to the maxilla and the pen receiver to the mandibular arch. The pen here has been opened to a point to where we are allowing the patient a 2 mm freeway space. Please note on the left, the amount of space between these teeth is the amount of loss of vertical dimension. The divider instrument on the right, which shows the dot on the lower at the bottom of the dot, and at the upper there is a space between the top of the dot and the point of the divider. This space is the freeway space. The pen was rotated to allow 2 millimeters of freeway space. The pen, when it strikes the maxillary striking plate, holds the maxillary denture in position and the mandibular denture secure to eliminate rocking of the prosthesis during the fabrication of the occlusal splint. It is suggested that the maxillary striking plate be coated with an ink solution so the practitioner can observe all of the movements while the patient is moving their jaw in different positions. On the lower right, we have applied ethyl methacrylate acrylic resin, which has been built up in order to fill the space of the lost vertical dimension. The pen is maintained at the occlusal vertical dimension. The patient is asked to close and then asked to slide their jaw forward and back, then side to side. The patient is asked to do this repeatedly. However, during the occlusal splint fabrication, we also want the patient to move in a lateral position, both in retrusive and protrusive. In other words, have the patient slide their jaws forward and back and in a circular motion side to side. This will assure that the occlusal typography of mandibular splint would have taken into consideration all possible movements, whether they are protrusive, eccentric, or retrusive eccentric. This occlusal splint is considered a functionally generated path splint. Once polymerized in the mouth, it is then put into a heated pressurized water pot to remove any excess resin monomer and complete polymerization. Note the apex on the maxillary striking plate. Once again, we see the arrow. The circle at the apex of the arrow is considered the chewing stroke. The amount of eccentric movement will only be the amount of the buccolingual distance of the chewing surface. This is approximately 2 millimeters. As seen here, as the patient moves forward, back and side to side, the amount of chewing stroke is approximately 1 to 2 millimeters. This is the complete splint which the patient will now wear to allow the muscles to rebound to their proper length and allow the patient to accommodate to the improved vertical dimension while the new prosthesis is being fabricated. Mounting the jaw recorders for the dentate and taking centric relation. As seen here, we have maxillary mandibular casts and fabricated resin bases to attach the jaw recorders. This is another look at the definitive cast and the resin bases. It is important that these resin bases do not come over top of the natural dentition. They should be allowed to only be on the lingual surfaces and will be made in order to mount the striking plate to the maxilla and the pen receiver to the mandible. We are now choosing the proper size for both the maxillary and mandibular arch sizes. Make small adjustments in order to assure a customized fit. Resin is now placed on the lingual surface of the pen receiver and then placed onto the base plate and positioned. This is a view of the lingual. It is important not to get the resin near the socket that the nut will be sitting in. This area should be free of any resin. The resin is now light cured until final polymerization occurs. Take the spacer paralleling snap and place this into the pen receiver. Next, place resin onto the maxillary resin base. Press this into position and then hold the mandibular and maxillary bases together to allow parallelism. Very simply, take the maxillary and mandibular bases, press them together, allowing the maxillary striking plate to move into its position, allowing for final parallelism. Light activate until completely cured. Remove the spacing apparatus. Now, place the nut in the socket with pressure. Next, place the pin with the dome pointing upward and adjust to the appropriate vertical alignment. As seen here, the pen can be rotated either laterally or anterior-posteriorly in order to be completely aligned once placed into the mouth. This demonstrates the completed setup for a maxillary and mandibular dentate patient. Once again, take a physiological rest position, then take the maxillary and mandibular acrylic resin bases with the jaw recorder placed into position and adjust this to the patient's appropriate occlusal vertical dimension. You are now seeing a rest position. After rest position is obtained, then rotate the pen down to allow for freeway space. In this case, we allowed 3 millimeters. However, when the patient began to slide the jaws forward and back, the teeth collided. In a case like this, it may be necessary to slightly open the pen. However, it must be measured and a face bow record be taken so that the vertical freeway space can be adjusted on the articulator. It is necessary to make sure that there is no interference during the process. Now place ink onto the sliding plate. Have the patient tap to be assured that the bases are seated without rocking. Have the patient slide the jaw forward, then back. Again forward, back, and then side to side. It is necessary to be able to see very smooth movement as the patient rubs forward, then back, and then side to side. Have the patient continue to do this until you are satisfied that the patient is not inhibited. Once this is completed, it will then be necessary to analyze the recording. As seen here, the patient has produced an appropriate arrow. At the apex of the arrow, some practitioners would like to make a small hole or dimple in the striking plate in order to have the patient be secure at the apex. Either cutting a small hole or dimple can be done or use the plastic receiving device. Once the patient is closed at the apex of the arrow, it is now necessary to inject bite registration material between the spaces in order to transfer this record to the articulator. This demonstrates a slight opening, therefore, this must be mounted with a face bow and then closed on the articulator to allow for the appropriate freeway space. This is your final jaw record. If a jaw recorder is going to be utilized on teeth that will be extracted soon, the patient may allow the practitioner to adjust the teeth to allow the jaws to move smoothly. In this case, we are closing the pen to allow 3 millimeters of freeway space. However, the patient has tooth interference. Since the patient will be losing these teeth, we have asked permission to adjust the teeth slightly in order for the patient to have a very smooth slide during their movements without the need to open vertical. This is the preferred method, especially if a patient is either having the maxillary or mandibular teeth removed. The patient now can move forward and back without interference and be at the appropriate occlusal vertical dimension. Once again, the patient will tap in order to assure that the bases are not rocking and then slide their jaws in a forward and back position and then side to side position. Once again, this is repeated until the practitioner is assured that the patient is sliding smoothly without inhibition. Again, when this process is completed, the practitioner must then analyze the tracing to be assured that the patient has produced a centric relation arrow. Next, the patient is asked to close into the apex of the arrow. In this case, the practitioner made a hole or dimple in the striking plate so the patient could secure the position while taking the record. It is suggested that a face bow record always be made. This demonstrates the patient's occlusal vertical dimension was taken at the appropriate vertical and no adjustment of the pen or the articulator was necessary. This is the preferred method when patients will be losing either one or the arches of teeth.